Welcome to today's webinar. My name is David Sykes. I'm the Director of the Centre for Dementia Learning here at Dementia Australia, and it's my great pleasure to introduce you to today's webinar. And we've certainly got a really great presenter out here from London who's going to talk to us about brain health. But before I go any further, I'd like to start by acknowledging the traditional owners of the land on which we're all gathered or seated, and in my case, pay my respects to the elders of the Wurundjeri Nation of the Kulin people and to their elders past, present and emerging. And we thank our partners today. We've joined with La Trobe University in being able to bring you today's webinars. So really great that we can have that partnership that's enabled us to bring the speaker out today to talk to us. Some housekeeping matters before we get into the webinar itself. So all your mics are muted. If you have any questions, add them to the Q&A. You can upvote the questions you would like to see answered using the arrow on the bottom of the question. The most popular ones will be put to our guest speaker today. It's obviously subject to time, but hopefully we get some time for some Q&A at the end. There's usually, in our experience with running these webinars, there's never enough time to answer all the questions. So we apologise in advance for this, but we seek to try and answer those ones that are most voted. So really encourage you to use that voting option. And, you know, that's certainly there for your benefit. So we're delighted today to welcome Dr. Nahid Mukadam, who's a professor of psychiatry at the University College of London and a consultant psychiatrist with the mental health liaison team at UCL Hospital. Dr. Mukadam's research focuses on dementia prevention, diagnosis and care, with a particular emphasis on ethnic differences and reducing inequalities. She's a member of the Lancet Commission, and she'll explain to you more about what the Lancet Commission is shortly, on dementia prevention, intervention and care, and of the European Consortium on cross-cultural neuropsychology, working internationally to improve dementia assessment and care for diverse communities. So would you join with me in welcoming Professor Mukadam?
Thanks very much. It's really great to be here. I'm very excited to see so many people online and to have had a chance to meet lots of very interesting and impressive people at Dementia Australia. Okay, I think is it time for me to start? So thanks very much for having me. Today, as the title implies, I'll be talking about dementia prevention with a focus on insights from the Lancet Commission and also the NIHR Policy Research Unit. So I'll just explain a little bit about both of those. I'm going to start by talking about the Lancet Commission, how it came about, what the process involved, and how we came to the conclusions we came to. I'll then move on to talk about the NIHR Policy Research Unit. Now, this is a government-funded research unit that aims to link with policy and policy professionals within the Department of Health and Social Care in order to conduct research that has relevance to policymakers. So my arrows do not seem to be working to advance the slides. Sorry about this. Hopefully we'll get some export. There we go. Okay, thank you. So just to start with the Lancet Commission. So the Lancet, which is, you know, the journal that you're all probably familiar with, commissions a series of sort of state-of-the-art reviews on various different aspects of healthcare. So, they have one on maternal health, for example, on climate change. So the Lancet approached Professor Jill Livingston, who's also based at UCL and with whom I work. They approached her probably around 2015 or 16 to say that they wanted to commission a Lancet report on dementia. And she included me in that group that was working on that. The first Lancet Commission came out in 2017, and then there have been subsequent publications in 2020 and 2024. The general approach has been to build on previous Lancet commissions. So that's for the latest one, of course. For the first one, we were really, going into it, not really sure what the template was meant to be. Obviously, we had other Lancet commissions to be inspired by, but we decided that we should try and make it as broad as possible and a useful tool for clinicians, academics, policy professionals, charities, anyone interested in dementia. And the remit was looking at dementia prevention, intervention, and care, so quite vast. We aimed to summarize existing research and best practice, and then for subsequent iterations, we aimed to summarize new research and also create new evidence of our own where we felt that such evidence was lacking, and then had to synthesize this all together and make recommendations so that, it was a useful document for people to have. So just because this webinar is focused on dementia prevention, I'll go through what our approach has been for dementia prevention. Over the last couple of decades, there's been a huge shift in our thinking about dementia. So it's gone from being something that people mostly thought was incurable and inevitable if you get older to becoming something that we think is actually very preventable, which has been great. There's been a growing body of evidence that shows, that there are some risk factors that are potentially modifiable that could impact on your risk of dementia. But of course, there's vast amounts of research with loads and loads of different risk factors. How do you decide which ones make the cut and which ones to include? We had to decide on risk factors with enough evidence to include in the Lancet Commission. And we generally followed the Bradford Hill criteria. So we needed to find, high quality, consistent studies, ideally cohort studies, which showed a dose response ratio that, where exposures and outcomes were validly measured. It needed to be biologically plausible. They needed to show temporality, so the risk factor occurring, way before the onset of dementia. Ideally, we were looking for studies that had really long-term follow-up. So where we found systematic reviews, these were prioritized because our reasoning was that people would have done a thorough search and applied quality criteria in order to summarize the effect of a risk factor on dementia risk. Where systematic reviews did not exist, we looked for high quality studies, and if possible, we conducted our own systematic reviews. Then the Lancet Commission team itself, there was a core group at UCL, but of course, we are, experts in some things, but not everything. So the idea was to invite experts from different fields to join us. And we had interactions online, lots of emailing back and forth. And then we arranged face-to-face meetings where the evidence for risk factors was presented and debated amongst everyone there, with feedback following the meeting and then eventual consensus as to which risk factors should be included. In the latest iteration of the Lancet Commission, we did new systematic reviews for the risk of depression, as in the risk that depression confers to dementia risk, and also hearing loss. And then once we had the risk factors that we were going to include, we then had to generate what's called a PAF, or a population attributable fraction, for each risk factor, and then for all of the risk factors together. So a population attributable fraction is a statistical construct. It's the percentage of cases of a disease that would be, in theory, eliminated if that risk factor was eliminated. So if the PAF for hearing loss, for example, is 8%, then the theory is that if you got rid of all hearing loss in the population, then the percentage of dementia cases would reduce by 8%. And to calculate it, you need the prevalence of the risk factor, so how common it is, and you also need the strength of its association, or the relative risk, with the disease. So a relative risk of 2, for example, means that that risk factor doubles the risk of dementia. And so the higher that number is, the more potent that risk factor is. Of course, that's just for the PAF for one risk factor, but we were aiming to look at multiple risk factors. So we built on work done by Professor Barnes and Professor Yaffe, as well as Sam Norton, who have published similar work before, but this time taking into account more risk factors that we all agreed should be included. And you have to, if you're doing multiple risk factors, we know that, risk factors tend to cluster together. So, for example, someone may have, diabetes and hypertension and obesity, and those risk factors tend to be quite related to each other. So you need to be able to take that into account when you're working out the overall potential for dementia prevention. Of course, there are limitations to this approach because, PAF is a statistical construct. It's theoretical. It's mostly based on cohort studies. So it's difficult to, if you can imagine, if we find that smoking is associated with an increased risk of dementia, it's not ethical or practical to do a randomized control trial of getting people to stop smoking to see whether their dementia risk reduces. So you're reliant on cohort studies that follow up people up over time, and you see what happens to smokers versus non-smokers. There's always the possibility of reverse causation, and this was an issue particularly with depression, in that we know when people are becoming depressed, when people are developing dementia, they're also tending to become depressed, and people with dementia often have depression as well. So, so there are many limitations. So I think we need to think of PAF as an indication of how important a risk factor is, rather than thinking of it as, the gospel truth that if you manage to get rid of a risk factor, you will definitely eliminate that percentage of dementia cases. I think we also need to bear in mind that the PAF supposes that one can eliminate risk factors, but of course, in reality, we may not be able to eliminate a risk factor. We could treat a risk factor, but sometimes people might not respond to treatment. So there are these are things to consider. It's not, but it's a rough indication of the relative importance of risk factors for dementia. So if we think about some examples where this has been, an issue, is hypertension is consistently associated with dementia, including in people who have long follow-up. So we're pretty certain that it is a risk factor for dementia. But there was a trial called the Sprint Mind trial, which looked at more proactive management of hypertension. And this found that there was a reduction in cognitive decline, but when it for dementia, the confidence interval included 1, which means there is it includes the possibility that there's no effect of actually more aggressive management of hypertension. And meta-analyses find similar. So again, this is the limitation of translating a PAF to a real world finding. For hearing loss, a meta-analysis concluded that there is an increased risk of dementia with peripheral hearing loss. And in longitudinal studies, people who wore hearing aids had the same risk of dementia as those without any hearing loss. So that indicated that if you treat hearing loss, then you can reduce your risk of dementia to the same as if you didn't have hearing loss in the first place. But a randomized control trial of hearing aids found no effect, except in a subgroup analysis and in people who had more risk factors. So again, there are some caveats there about, whether we can treat, whether treating risk factors actually does reduce dementia risk. Diabetes, we know that there's an increased risk of dementia if you've got diabetes, but studies have found that if you control your diabetes more intensively, that doesn't reduce your risk of dementia compared to people who don't have that aggressive control. Again, indicating that, maybe getting rid of diabetes or treating it is not going to have an effect. However, some studies have found that some medications for diabetes reduce dementia risk more than others, particularly the GLP-1 RAs. They're in the news all the time these days. Things like Ozempic and Mounjaro for treating obesity, but they also seem to reduce dementia risk in people with diabetes. So that's some promising findings. So this is the diagram that we made for the Lancet Commission last year, showing that overall, if you put together all of these 14 risk factors, the potential for dementia prevention is 45%, meaning that up to 45% of dementia cases may be preventable if all of these risk factors were addressed or eliminated. And you can see that some of the bigger circles are hearing loss and high LDL cholesterol, which are 7% each. So in theory, if we eliminated hearing loss, 7% of dementia cases would be prevented. And the main reason that those numbers are so high is because hearing loss in older people is actually really common. So it's the prevalence that's driving this increased PAF compared to some of the other conditions, which are equally risky in terms of dementia risk. So then we wanted to see whether, what would be the impact if we treated some of these risk factors. We wanted to see the impact in terms of numbers of dementia cases, but primarily about the economic impact. So we conducted a systematic review using PubMed and Web of Science, and we looked for individual level interventions that successfully targeted any of the pre-specified potentially modifiable risk factors. We needed to find robust evidence that the intervention improved the risk or the risk behavior, and that the intervention was feasible in an adult population. And then the health economic calculations were done by our colleagues at London School of Economics. We took a societal perspective, so including health and social care costs and also unpaid carer costs. The other side of the equation was the cost of the intervention itself. And then essentially we were comparing the incidence of dementia in people with the risk factor that were treated and then without the risk factor, and looked at reduction in incidence, and that then translated to costs and changes in quality adjusted life years. So what we found 4 interventions. So hearing aids for people with hearing loss, antihypertensives, and we modeled quite aggressive hypertensive control, so with up to 3 antihypertensive medications. We modeled smoking cessation. All of the methods were roughly equivalent, so we looked at nicotine replacement therapy in the form of chewing gum, and then diabetes prevention, which was based on a lifestyle intervention from one of the European countries. And what we found is that for the 3 interventions, hearing aids for anyone who needs them, antihypertensives, and smoking cessation, if those were given to everyone who needed them, we would get an 8.5% reduction in dementia prevalence. And this would equate to about a £1.9 billion per year saving in health, social, and unpaid care. This was for England alone. We had to model it for just one country because the costs of care and so on are very country specific. Preventing diabetes was not cost effective if we were taking into account dementia risk alone. Obviously, there are many good reasons to prevent diabetes for other reasons, but when it came to dementia, it wasn't cost effective. The caveats that we had for this work was that not everyone will accept an intervention. Not everyone who has a risk factor may even be known to health professionals. And then even if they are, they may not accept an intervention. Not everyone who has the intervention will have the same effect. So it just may not work in some people. And then we don't know whether these interventions treating risk factors will actually have an impact on dementia incidence. We assume it will based on all of the work that's been done so far, but we need, there isn't any really hard world evidence to show this. And then also the question about generalizability comes in as well. This was based on England. How would it translate in different areas where there's different prevalences of these conditions and different treatments? So this building on the generalizability issue, the cohort studies that we have used for most of our meta-analyses and have cited in the Lancet Commission are mostly in primarily white participants in primarily higher income countries, because those are the places that tend to be doing this research. The UK has quite a large minority population, as does Australia, and we know that in some studies, so for example, the SABRE study based at UCL, which was looking at cardiovascular risk factors, having a cardiovascular risk factor increases your risk of stroke and cardiovascular events more in people from minority groups compared to the white population. So having the same risk factor can have a bigger impact in minority groups. So then the potential for prevention may be even greater in minority ethnic groups. And but we know that healthcare systems are highly unequal. Not everyone has the same level of access or the same treatment as if you're from a different ethnic group, there may be variation. So ideally, what we should be doing is trying to target the whole population so that it's more equitable, so that everyone has the same opportunity, because individual level interventions like we've just discussed in the previous slides may exclude a lot of people, and therefore you're losing out on dementia prevention potential in a large part of the population. So we did some work to see about dementia prevention potential in different settings. So we looked at lower and middle income countries, so China, India, and then 6 Latin American countries. And we found that the potential for dementia prevention was greater in all of these settings. So this was only the 9 risk factors. So this was the 2017 Lancet Commission, where we found 35% of dementia was potentially preventable. So you can see that these figures are all higher than that figure, and that's we use the same relative risk. So the reason for the increased population attributable fraction is the prevalence of these risk factors. And you can also see that there are different patterns in which risk factors tend to be more important. So if we look at social isolation is really a tiny concern in Latin America, whereas it accounts for more cases in India, for example. Less education is quite a big number. The PAF for that is quite a big number in all of these settings, whereas other countries that have compulsory education until 16 or 18 will not see that same pattern. So it's important to think about your country, but even within a country, about different regions within the country, because they may have different dementia prevention priorities. So we wanted to see whether changes in risk factors had an actual impact on dementia incidence. And this is just one example. This is from UK data. So showing that over time, what we did was we did a review to find cohort studies that had measured dementia risk factors as well as dementia incidence or prevalence at least 2 time points. And what you can see is that over time in this, so this was the CFAS study by Matthews and Carol Brain and others, showing that over time, so this is over roughly 2 decades, the relative importance of risk factors changes. So at the bottom, you've got the highest PAF, so that's education. So people who had less education, their PAF for dementia was about 11% at the first time point. But over time, as you get this cohort effect where education became compulsory over time in the UK, and so actually people who are having less education reduced over time. So you can see in the right side panel, the PAF for education has now reduced to 5.3. So it's basically halved in that time, whereas diabetes is right at the top on the left side panel, only 1% of dementia cases. But over time, the prevalence of diabetes has basically more than doubled. So it's now a relatively more important risk factor. And there were quite a few studies that measured dementia prevalence and incidence and risk factors at 2 time points. But the limitation with that is that you can see how the PAF of these risk factors changes, which is useful. So you can see what's relatively more important, what do we need to be focusing on next. But it's not allowing you to see how a change in risk factors then translates to a reduction, or maybe not a reduction in your dementia prevalence and incidence. So there were very few studies that had allowed us to look at that. The one that stands out is the Framingham study, because there were multiple waves of data collection. And what that found, or what we found when we looked at that data, was that a reduction in risk factors, PAF, over time in the subsequent decades translated to a reduction in prevalence and incidence of dementia. And the main risk factors that seemed to be driving this were smoking and less education. So many countries, higher income countries, have introduced policies around minimum levels of education and also have introduced smoking bans. So I think, so that it just shows how powerful policies at the population level can be in terms of your impact on dementia. Sorry for the lots of text in this table, but this was essentially a paper that where we tried to examine the economic impact of population level prevention. So we first did a systematic review looking at population or policy level interventions to address dementia risk factors, and then did economic modeling to see what impact that could have at the population level. And if you look at the sort of bottom pink row, essentially the cost savings for if we implemented these interventions and then they had an impact on not only that initial cohort but successive age cohorts, you get some really big numbers. These are all savings in pounds for England for applying these interventions to current and future generations. And then the quality gains at the bottom are also extremely high. So we're looking at potentially, billions and billions of cost savings in terms of their impact on dementia. So overall, I think from the Lancet Commission and this other work, we've found, very little randomized control trial evidence, which is usually seen as the gold standard. But I think even if we don't have that, I think the cohort evidence is pretty strong that these risk factors are associated with dementia, and that these interventions that we've discussed not only can be cost savings just for dementia, but they're also likely to have the benefit on multiple other conditions. So if we think about smoking, for example, we've already shown that it's potentially cost saving in terms of, if you stop smoking, it's cost saving in terms of dementia, but it also reduces your risk of, cancers and heart disease. So the benefits are, potentially much, much greater. And, applying it at a population level could have a really big effect. So I guess what we need to think about is within our countries and, within different regions in our countries and within different ethnic groups in our countries, what risk factors are most important, what are associated with the highest risk of dementia, and how do we address those ideally at a population level so that we're not reliant on, people with more resources and more time and more health awareness to go and seek out these interventions, but, that they have the potential to improve their health without having to have individual agency. So having, completed this Lancet Commission work, I'm now going to move on to how we've tried to translate some of these findings into, real world action and policy change. So I'm going to talk about what our modified Delphi study, which was run by Harriet Demnitz King and others, as you see on the screen, on behalf of the Dementia and Neurodegenerative Policy Research Unit run out of Queen Mary's University. And then I'll also present a public survey data analysis that was primarily conducted by a PhD student visiting from the Netherlands, along with my other colleagues, and see how we translate these findings into real-world action, but also the public awareness of dementia prevention, what state that's in, and what we need to do going forward to ensure that people are getting the message about dementia prevention. So the Delphi study was to get together a group of experts to develop and agree upon national policy recommendations for dementia prevention. We used a workshop and then a modified Delphi survey. So the first step was to form a steering group, which was a relatively small number of people who were focused on this question, and then also engaged a wider group of stakeholders, including the Department of Health and Social Care and NHS England, as well as academics and lay advisors. We conducted multiple focus groups and then a large in-person workshop, and this was followed by multiple rounds of online surveys about messaging around dementia prevention and what the priorities should be. So we developed 56 evidence-informed policy recommendations around public health messaging, what that should look like, about what interventions for risk factors should be focused on, also population level interventions and research commissioning. So where should the money be going? And looking at a health inequalities lens throughout. So in general, for public health messaging, we wanted clear, actionable, and targeted advice for reducing dementia risk that begins in midlife. And so some of the recommendations were, talking about reducing risk rather than, stopping risk, and also the feedback from our public and patient involvement suggested that we should group risk factors into common themes, like, for example, lifestyle factors, rather than, because 14 risk factors is quite a lot for anyone to take on board. So they thought it might make more sense if it was, grouped into, say, lifestyle factors or heart health factors, so that people can, get on board with the messaging and start thinking about how they can include these factors in their lives. For individual level interventions, we agreed that there should be a focus on promoting health equity. But we didn't manage to reach consensus about what risk factors matter most. I think, everyone has their pet favorite, either because of what field they work in or because of what they think can be achieved in that field. So there was less consensus there. And we all agreed that we should look at the strength of the epidemiological evidence. So ideally, randomized control trials, but where these do not exist, then long-term, well-conducted cohort studies, ideally with inclusion of the whole representative of the population underlying it, rather than just the highly motivated, educated, well-off people. There was consensus on population level interventions, and we thought that this should be integrated into non-communicable disease prevention models, because there's already quite a lot of campaigning around, reduction of excess alcohol use. We've had the smoking ban. There's, a lot of focus on reducing sugar to try and reduce obesity. So, if we can work together across different government groups, then, we'll reduce repetition and potentially have a greater impact. And there is a lot of interest in identifying scalable and equitable interventions that require relatively little personal agency. And we need greater refining of public messaging around dementia prevention across the life course, and also thinking about how to target different groups. So some risk factors are, increased in some groups. So, for example, South Asians have a 2 to 3 times higher risk of diabetes than the white population in the UK. So how do we get that messaging across that, these are the priorities for your health and they will have an impact on brain health? So following that Delphi consensus, we had consensus on many of the factors, but not all. We have submitted a peer-reviewed publication, which will hopefully be accepted. We've produced a policy brief. There's been presentations both in academic and sort of lay forums, and then future steps. We're going to try and refine this so that we have some more specific recommendations to provide for health agencies and policymakers. Now, the second bit, the second study that I'm going to present is about knowledge of dementia prevention and dementia risk. So we know that we know that potentially modifiable risk factors are important to address, but there still is a lot of stigma around dementia itself, and also relatively poor knowledge about the potential for dementia prevention. We know that people from minority ethnic groups are at higher risk of dementia, but they are underrepresented in research and also campaigns. So one of my patients sort of commented to me that, all of the, for example, they were looking at adverts, about promoting stroke awareness, and they just feature white people. So she, as a South Asian, didn't really feel represented, didn't feel it was relevant. And I think, we need to think the same about dementia prevention awareness campaigns as well. Most dementia risk research is focused on white European origin populations. So it's important to understand how different communities perceive dementia and brain health. So the aim of this study was to explore attitudes, stigma, and knowledge about dementia and brain health across ethnic groups so that we can inform targeted prevention strategies. So we had data from two large UK-wide surveys for over 3,500 people conducted by Alzheimer's Research UK. They were all online, and there was also some telephone interviews as well between the dates on the screen. And they used questions that were aligned with public health and brain health frameworks. So what we looked at was knowledge about dementia. And this was questions asking directly about dementia and what it means, about stigma. So this was asking whether people, if they developed dementia symptoms, whether they'd be willing to discuss the symptoms with anyone. There were also questions asking about whether it's possible to reduce your risk of dementia. And then there were some questions about brain health and what factors affect that, and also lifestyle and how this affected brain health. We conducted regression analyses. Our hypothesis was around ethnicity and that there would be differences in ethnic groups in the outcome measures. So we divided ethnicity into white, South Asian, Black, and other. These are South Asian and Black are the two largest non-white minority ethnic groups in the UK. That's why we focused on them. And the other group was really quite heterogeneous because we didn't have the numbers to do any further sub-analyses. So the main outcomes, as I said, were knowledge about dementia itself, stigma, belief in dementia risk reduction, and then awareness of brain health. And we adjusted for age, sex, social grade, education, having a chronic health condition, and knowing someone with dementia. And what we found was that South Asian and Black participants had lower dementia knowledge and higher stigma than white groups. And despite a higher education or social grade, these groups still showed gaps in dementia-specific awareness. There was general brain health knowledge. So everyone seemed to understand that, looking after your diet, exercising, these were all things that could improve your brain health. But it didn't translate to connecting that with dementia risk reduction. So people didn't seem to make the connection that improving brain health would equate to reducing your dementia risk. So I think, we need to think about when we're trying to raise awareness about brain health, that we're specifying or making that link between brain health and dementia explicit, because as was apparent from this piece of work, people don't necessarily connect the two. Oops. Education and loan. So the sample was, probably not representative of minority ethnic groups in the UK. It was, online, so that's one limitation. It was all in English, and also the people who were taking part were generally higher educated than the South Asian or the Black population in general in the UK. But we know that even in those people who are relatively higher educated, there still is stigma. There's still not that much awareness about dementia. And interestingly, chronic illness was linked to lower dementia knowledge and more stigma. So we need to tailor our education efforts. It's not enough to just keep sending the same message out. We need to tailor it to, what people already know, what's particularly important for them. And of course, the equity issues with digital interventions and surveys is considerable. And without adapting them, thinking about different languages or easier read formats, they may actually be making disparities worse rather than reducing them. So we should be thinking about co-developing these with minority ethnic communities and also people from other underrepresented and underserved groups. So in summary, there's still a large gap in the population in general, but particularly in minority ethnic groups around dementia risk, and also still lots of issues about stigma around dementia. So we need to be thinking about initiatives that are prioritizing inclusivity. We need to be working with people with lived experience and collaborating across different sectors to ensure the message is getting out and that it's received and acted upon. These are just some acknowledgements for the work, funding for this work. And that's it. Thank you so much for listening, and I look forward to your questions.
Thank you very much, Professor Mukadam. It's wow, there's a lot there, isn't there? And I can see we've got a lot of questions coming through. So I might jump on in to the hearing losses certainly garnered a level of interest. And one of the questions is around, can you speak to the underlying mechanisms for hearing loss increasing the risk of dementia? Is it that patients with poor hearing are less likely to present to health professionals, or is it that lack of stimulus input causes neuronal damage?
Yeah, that is a very interesting question, and I think one that several studies have tried to answer. And as with most things with brain health, the answer is complex and multifactorial. So there seem to be multiple mechanisms by which hearing loss results in dementia. Part of it is a lack of stimulation. So we know that keeping your brain active, engaged, gives you what's called cognitive resilience, so that you have relatively the ability to deal with neuronal damage more. So if you're losing your hearing, you have less input, less signal coming to your brain. It's stimulating your neurons less. That's resulting in itself in potentially brain shrinkage and an increase in dementia risk. Losing your hearing also makes people sometimes withdraw socially. We know social contact is very important to maintaining brain health. So it could be that social withdrawal is also resulting in
Yes, I wondered about that.
Its own impact, and because social isolation is itself a risk factor for dementia.
Yes.
And also, if you're doing all of that, you're becoming more isolated. Maybe you're not doing the things you used to do. There's less cognitive stimulation, but there's also potentially developing depression, and again, depression is a risk factor for dementia. So all these multiple pathways that are sort of working together to increase dementia risk.
And is there a particular point? This is another question still on the hearing aid question or hearing point. Is there a particular point where it's recommended hearing aids for that or what point does that actually considered it? Like if you let it go too long, is that more of a factor? Is there a kind of just right, just in time kind of point where hearing aids are likely to have that benefit? I suspect a tricky one to answer, but
yeah, I mean, I guess nobody's measured it specifically, but I think like with anything, the longer your brain is without stimulation, the longer you're accumulating any sort of neuropathological damage, the worse that is for your brain. So I would say, and hearing loss is so common, over the age of 50, up to, 50% of people may have hearing loss. So I think it's important if you have any suspicion at all that your hearing is not what it used to be, or if your friends or family are telling you that your hearing is not what it used to be, definitely get it checked out. There may also, I mean, nowadays in the UK, there's centers that will, in one of the chemists, for example, you can go and have your hearing checked. So, why not do that if you're at all concerned, or even if you're not that concerned, but you're getting older and you just want to have it checked, just like we would check blood pressure. Do it. And then if you find something, then it's relatively straightforward to get a hearing aid.
No, good advice. And so if hearing aids help reduce the risk factor and certainly managing that, does treating depression with antidepressants have the same impact on reducing that risk factor?
Yeah, that's again, it's something that's not really been teased out well in the research. I think it's quite a difficult thing to tease out, because in most cohort studies it would be, of course, unethical to have people who were depressed and not getting treatment. So it's not clear that treating depression will definitely reduce your risk of dementia, but I think there are many good reasons to treat depression anyway. We know that, depression is associated with many, with higher rates of chemicals that will be doing neuropathological damage, sort of inflammation and so on. So I think there's very good reason to get depression treated, and we assume that that will also have a benefit on dementia risk reduction.
Thank you. And Sandra posted a question around the two population interventions that seem to have the greatest cost saving were reducing added sugar and salt in foods. She's just interested in your thoughts on those two.
Yes, so we had to make a lot of inferences, but the studies that were done to demonstrate that were pretty good evidence that reducing salt in your diet reduces your risk of high blood pressure, and high blood pressure is one of the a really important risk factor for dementia. And then reducing sugar intake was also associated with reduced risk of obesity. So yes, and those are potentially two very powerful interventions that most evidence suggests doesn't have a huge impact on palatability of food, or doesn't cause major changes to people's diets. But I think it's about working with producers of food and trying to incentivize the reformulation of food so that it's a relatively uninvasive intervention that doesn't cause much disruption, but could have a huge effect at population level just because of the numbers of people that it affects.
Yeah, no, good point. Amanda's posted a question around what's the best advice you can give clinicians when counselling patients in the context of the associated risk with repetitive hand injuries, to do with playing sports particularly, and the development of CTE-related cognitive impairment. Is there enough evidence yet to determine the relative risk in that context?
Yeah, so we know that any head injury influences your risk of dementia. Obviously, the more head injuries you have, the worse it is. And the worse the head injury is, the worse your risk of dementia is. So if you have a relatively minor bump, not that frequently, it's not as bad as if you have a head injury that knocks you out unconscious, for example. So we know there is that dose-response relationship. Sport is generally good for you. Any sort of physical activity is good for you. It's good for your brain health. So I think we've got to have a balance between, highlighting the risk of head injury, but also not putting people off sport. If there are things that sort of, national sports bodies can do to ask people to wear helmets, for example. So there was a New Zealand study looking at, which we used in that paper with all the costs in it, looking at wearing a helmet for children actually cycling, and and we use that to show that actually even wearing a helmet so that you reduce your risk of head injury if you have an accident on your bike does eventually potentially translate to reduced dementia risk. So definitely protect your head. Don't stop doing sports, but just be aware that your brain is important. It needs to be protected.
And look, a final question for you before I close is, why are governments not pouring funding into dementia prevention education for the population, given those huge potential cost savings to them?
Yes, I think often with academia, the results of academic papers, although they might, get a bit of attention, we've produced a policy brief around this. We're obviously working with the Department of Health and Social Care, but I think all governments have their own agendas, their own, priorities. In the UK, certainly there's been a shift with the new government to deprioritize dementia. So we used to have targets for dementia diagnosis rates. Those have been shelved for now. So I think it's about, how do you work with governments to highlight the, how the priorities that we have that we can see make them align with government's priorities, because often the timings for these impacts are so many years down in the future that governments may not see it as very relevant for them now.
Yes, the 3-year term or the 4-year term or whatever it happens to be
Yeah.
of government and what they need to do in that context. But Professor McGuinness, it has been wonderful to have you take us through the growing body of evidence around this, and really insightful. I'd now like to introduce our own professor, Professor Tanya Buchanan, who's the CEO of Dementia Australia, to say a few words.
Thank you, David. And look, it's the last day of World Alzheimer's Month, so what an erudite run through prevention work. So thank you, Professor Mukadam. It's been incredible, and it's been lovely to hear from you. And I also want to acknowledge our friends at La Trobe University, who very generously have worked with us to make this possible today. So thank you very much. I do need to also today, before we wrap up, take a moment to acknowledge the incredible work and to thank Dr. David Sykes. So many of you on this call will know that today is actually David's last day here at Dementia Australia. And while we know he is going to go on and do fantastic things in the aged care sector more broadly, we have no doubt about that, we did want to just take the time to thank him for the work that he's done both at Dementia Australia, but in the sector more broadly. And his impact has been immense and will continue to be felt. And I thought it was just really important to acknowledge him in this forum as his last webinar with Dementia Australia and the Centre for Dementia Learning, and to wish you all the best, David, from all of us to you. And we know you'll stay in touch, but congratulations on all you've achieved, and our very best wishes for your future endeavours.
Thank you very much, Tanya. And look, it's been an absolute thrill and a privilege to lead the amazing team here at the Centre for Dementia Learning, and made all the better by the engagement we've had with all of you out there. The webinars have had a huge response. We get over 2,000 to many of these, and I know the ratings we get on them is just phenomenal. So we do feel we're serving a need and hitting an interest that you all have in continuing to improve the lives of people living with dementia, but also their families and carers, and improving your own care of people living with dementia. And that's why we're all here, to do that. So I think today's webinar has been a really great opportunity to see what we can all do to promote reducing the risk of developing dementia with others in our own lives, and probably a fairly poignant one for me to be my last one in many respects. But I do thank Tanya and the amazing team we have here at Dementia Australia that does some phenomenal work at really supporting so many of you who are supporting people living with dementia to really lead their best lives. So thank you. Do want to also, I know Tanya did, but I'll also acknowledge them as well. So La Trobe University, again, thank you for supporting today's and being part of our bringing this webinar to you today. Certainly the October webinar we've got coming up, there'll be more information coming out to you via the usual EDMs. So look out for that. I won't do any spoiler alerts on that one. I'll encourage you to look out for that and look forward to, well, I won't looking forward to, but I might look forward to watching the next webinar. So thank you very much. Enjoy your day.